The old amyloid beta hypothesis is failing us, right? There's new innovative ways of looking at Alzheimer's, dementia as brain inflammation, right? But how do we measure that? My patient's not going to say, I have inflammation going in my body unless we actually measure them.
That's right.
So we're actually, as practitioners, just catching up where the field already is. And that's what I'm finding very exciting is that
with this podcast, what we're trying to do is have real, authentic discourse.
Dr. Latif, it's great to have you here today.
Great to be here.
I've been looking forward to doing this one with you. As you know, had talked about, we are having our podcast this year. It's called Treatment Redefined. And really the objective is to have thought leaders that are really pushing the envelope on treatment in the addiction and mental health category and trying to have good, authentic conversation around this subject, which is a big subject in our country. So for the guests that are listening, you are Enterhealth's Chief Medical Officer. Maybe just give people just a touch of your background, just your education, your training, a little bit of your history prior to joining us.
Yeah, sure. Now, glad to be here. I'm excited because I think these are important, timely conversations. And what's interesting for me as a physician is it's our patients who are leading these conversations.
That's right.
And not so much the medicine field. And I think that's how medicine should be. So by way of background, I'm a board-certified psychiatrist, certified in adult and geriatric psychiatry and addiction medicine, and also a distinguished fellow of the American Psychiatric Association. And I mention these things to highlight the level of background training, but that training really doesn't translate into clinical practice. What really translates into clinical practice is what our patients have taught us and the art of listening, truly listening to our patients that informs the way you practice. And we're going to be talking a little bit about this today as we go along.
Yes, actually, I think that's a great point that you just made, which is you can have all the training and education in the world, but until you actually go in to the arena and get the experience and get the feedback, that's where the real learning and understanding comes from. Great. Well, let's jump into a few things. So you serve as our Chief Medical Officer. You've served in a variety of capacities prior to joining us. You have an outpatient program just north of here, the Noesis Clinic. And so just with your history and of working in a variety of different areas, maybe just give people a feel for why did you decide to jump on our train and go on this journey with us?
Yeah, no, absolutely. So one of the things I've been involved over the last 15 years is co-founding, developing, and expanding nationally programs that are evidence-based for our active duty service members and veterans, where in our civilian hospital systems, we would receive those patients and help them in their path to recovery. And oftentimes the clinical need was co-occurring disorders, trauma combined with addiction, and there's a special training and skill set that's needed to merge both of those things together.
Yep.
And what I found was that we could have really experienced clinicians who do trauma work very well, but they don't feel comfortable in understanding what phase of recovery or relapse is their patient in. Or vice versa, some really good addiction therapists who are not trauma-informed or trauma-trained, and in that gap, our patients were suffering. So it was incredibly rewarding over the last 15 years to develop and build those programs. And part of that program development as the National Medical Director was training psychiatrists, nursing staff, therapists into culturally informed, evidence-based care. And something interesting started happening after COVID that started to hear the language of trauma, not so much from our patients, but also from our clinicians. This concept of burnout started to become pervasive that was well known in this field, but a new angle started to come in of the construct of moral injury. So it wasn't just about, is it the seed or is it the soil, the environment within which practitioners were practicing. And what I saw a shift over the last decade plus was that there was a hyper growth mindset in managed care where corporate practice of medicine, the thin veneer was starting to crack.
That's right.
And that was directly translating into poor patient outcomes, but also clinicians were losing their soul, their why of practicing medicine. They were just becoming data clerks on here's a symptom, what is the billable code, what will managed care prior authorize and allow me to practice. And the outcomes are very much driven to the bottom line. So it started to become profits over patients. And I want to be clear, I'm not suggesting that corporate healthcare is not good. But some of the background and the culture that came from venture capital, where you want a hockey stick return on things, and their ethos is build fast and break things. Well, these are human beings. These are lives that are coming to us, entrusting us with an opinion, asking us for hope in recovery. And it started becoming very constraining, that practice of practice of medicine.
No, I completely understand where you're coming from. And when you and I had a chance to meet for the first time, this was some of the dialogue that we have. And I've always been a big believer that how you start things and how you set things up is going to dictate a lot of future decisions downstream. And there's lots of different business models and lots of different industries. Healthcare is a big part of our economy, but it's also something that's very personal and I think needs to be handled with care, no pun intended, but it really does. And when you have business models that are put together to drive returns very, very quickly, and then with the ultimate goal is I'm going to sell it off, it dictates a lot of decisions. You end up getting into a lot of cost management, reducing the cost, putting a lot of debt on these businesses to drive revenue as quickly as possible to then sell it off to somebody else that's going to do the same thing. And there's nothing wrong with that. Actually, those are all variety of ways that people have built successful businesses. But I think in healthcare, the right approach is to lead with the patient and move backwards. What is right for the patient and the family? And I've always believed that if you build something that works for patients and you do it the right way, the business will come, not the other way around. And so when we started Enterhealth, like I had told you when we first met, it was very humble beginnings. And we built something for the community. And we realized that there was a huge need out there of people suffering with addiction and mental health. How do we do this differently? How do we do it better? And that's been our tagline for 17 years, a better way to recover. Now, we don't have all the answers, but we are on a hungry march to try to incorporate all things that are credible, evidence-informed, and bring them to the practice of addiction and mental health. I think it's the right way to do it. So Enterhealth, you joining us, we're a treatment program. Lots of different places that you can go to get addiction help, mental health help. You can go to your psychiatrist one-on-one. You can go to a therapist one-on-one. You can go to a inpatient acute care hospital, probably spend 5 to 7 days. Then you're typically bounced right out to an outpatient program. We were a little bit different, I think, in the market. We're primarily a residential treatment program with a outpatient center of excellence that can be a place of entry, but also a place to continue the care once you've completed treatment. So when we came into this field, we realized that addiction is a complex issue. It's not something that's acute that you can get over in a quick period of time. Matter of fact, I think I remember back, I'm trying to remember the Surgeon General's report, it might have been right around 2016, 17-ish, talking about really what's the right way to treat addiction. And it showed that you really need 2 to 3 years to achieve the right rates of recidivism compared to other chronic issues, other chronic things that people suffer from. And as I read through the report, I thought, gosh, this makes so much sense because it's actually the approach we've tried to take, but why isn't this implemented? A lot of it has to do, I think, with incongruency around what payers are willing to pay for versus really what the patients need to get better. We'll hit on some of that here a little bit later today. But in going through and putting Enterhealth together, one of the things we realized, it is complex. It requires a multitude of different disciplines to come together. You've got therapy, very, very important. It's probably the one area that patients spend the most time doing. Individual therapy, working with families. Families are absolutely essential to helping patients get better.
Yeah.
You've got sorts of testing. You've got neurocognitive testing. You've got, as you know, we incorporate MERT, neuromodulation. So coming to you, psychiatry.
Yeah.
Psychiatrists play a role in this. So let's back up here, because a lot of these treatment programs have doctors.
Yeah.
Then you've got psychiatrists. So in your mind, what is the role of the psychiatrist in our treatment program?
Actually, what's fascinating as I'm hearing you say this is you've actually described what integrative medicine is. And Enterhealth's been doing this, I think, even before that became a buzzword.
That's right.
Putting the patient at the center of it, allowing a long enough time to really have the patient at the center of their treatment plan and bringing to their care whatever is the best informed care available. So, talking with Dr. Urschel, one of the things that was impressive about Enterhealth was, even way back, Enterhealth was looking at innovative ways of medication-assisted treatment before anyone else was.
That's right.
Integrating Suboxone before anyone else was. And now, when I've joined these systems of care, advanced levels of transcranial magnetic stimulation. We had, I think, Dr. Miller in one of the previous podcasts.
That's right.
Who speaks really well on that. I would encourage listeners to take a look at that podcast. But also coming back to root cause analysis, right? So where I feel the role and the importance of psychiatrists is psychiatrists sit at the center of collating a lot of different specialties and bringing it together to have a science-based, informed treatment plan that still has soul to it, right? Because psychiatry, I think, more so than any other medical specialty, is truly the merging of both science and soul.
I agree.
Right? So Dr. William Osler, one of the giants of medicine, he has a quote, we'll see if we can put it in the show notes, where the practice of medicine is truly an art, and it's a calling. And it's a calling that actually tests your heart as much as your brain.
That's right.
And the day we forget that, then our patients are just data points.
I completely agree with this. I'm going to just share a little insight. I was meeting with a dear friend this past weekend. We were together. He's an ER physician trained in integrative medicine, and we were talking about just the evolution of different training with different doctors. And what he and I were talking about was kind of rheumatology and psychiatry, and how over time with the way the system has kind of evolved, we've got real narrow and deep, but we're narrow.
Yeah.
And we're becoming, if we're not careful, you talk about the art, because I want to hit on that, because I really think in there is an art, but it's also critical thinking.
Yes.
And if we're not careful, we're going to dumb these different disciplines down to really process and protocols.
Yes.
So I feel like your role within a treatment system, you have the opportunity to practice the art of medicine with the time that you have and the critical thinking that you presumably went to med school to do.
Yeah. And one of the things is that I'm personally enjoying as a clinician and discussing this with the team over there is that it's giving a space to innovate, right? It's that the more you learn, the more you know, how less you know, right? And there's not enough time for that mental capacity to be even curious about, has the medical science caught up with what I learned in med school 20 plus years ago? Actually, a little bit more than that, right? Yep. So this is a place where we can pause, grow with our patients. And one of the dirty secrets, I think, about our current healthcare system is the word evidence-based, as if that is the ultimate litmus test of what we can provide care to our patients.
That's right.
There's actually very compelling data that over the last decade, we have been training a cohort of medical students and and residents based on research that more than 80% is just funded for drugs and devices. So if that's all our current crop of doctors know, that's all that's in their toolbox.
That's right.
Right? And we're talking about biomarkers, right? We're talking about, but I would argue an interesting point. The first biomarker when we're sitting across with our patient is the story they're telling us, right?
Agreed.
And if we don't listen to our patients, if I could have this elegant analysis of a deep dive into my patient's genomic SNPs, but how do I translate it into the person sitting in front of me? And that's what patients have been lacking. They're tired of prescription roulette, right? And they're trained implicitly in our healthcare system that by the time I've stopped seeing my therapist and I've gone to my psychiatrist, the only value of my psychiatrist is a glorified pharmacist.
That's right.
Well, one of my patients got me this big old ugly orange bumper sticker a long time ago that said, "Lord, help me be the person my psychiatrist medicates me to be." Right? And I talked to colleagues and they've forgotten that they're trained in therapy. They're trained in psychosocial assessments. They're trained in trauma-informed treatment, right? The seminal work, that book, The Body Keeps a Score. I would argue that in addiction medicine and addiction psychiatry, that's the one place where you cannot ignore the medicine, the brain science and the body science, right? Because psychiatry has been treating the brain as if it's a floating object that's not connected to the body. And there's a lot of key essential elements that are micronutrients that are not being absorbed because of gut inflammation, or there might be genetic variances in how they metabolize things or how they produce essential amino acids, how they produce essential neurotransmitters. These aren't just kind of, oh, it'll be nice to test them. These are vital, key clinical data points. If we don't test them, how will we know that?
No, you are so right on. And this is really, I think, a great segue into some new areas that we've been trying to bring on together. You know, when you and I first met, we I think, ran across the field on a lot of issues together. But one of them was this idea of why is there not more blood work done? Why is there not more objective analysis done? Why is there not more like a functional medicine approach that you see in other areas of internal medicine being applied to psychiatry? There's different nomenclature around it: functional medicine, functional psychiatry, integrative psychiatry, precision psychiatry. But really it's getting to what I think you just said, which is the brain and the mind are connected to the body. They interrelate. And we're not looking at all the pieces of the puzzle. We've kind of relegated ourselves to looking at primarily symptom management. Maybe it's a result of the time that we have or the training that we've sent a lot of our medical students through. But it's time for this area to move because at the end of the day, the results speak for themselves. Patients don't get much better under the traditional way of doing this.
Yeah.
So it's time to evolve. Yeah. So this area, functional psychiatry, you and I teed up last fall, and we had a chance to I learned a lot from you because I'm not a medical doctor, but I shared a lot of the ideas that I had around why I think we should look at these things. And we had a chance to meet a really interesting man named Dr. James Greenblatt, which I think is one of the foremost leaders in functional psychiatry. And he's now helping us to stand this program up within our treatment system. You're now trained in it, becoming more informed in it, or other practitioners are too. And I feel like this area is a little bit like the vanguard to new areas of psychiatry. Would you agree with that?
No, 100%. Our patients are already in this space. Our patients have intuitively known for a long time how the body is impacted by mental processes, good or bad. You know, I carry my anxiety in my gut. We've known about, the gut-brain connection, the vagus nerve, for a long time, but we weren't able to really put that data together and put it all in a comprehensive way. new research on Alzheimer's, the old amyloid beta hypothesis is failing us, right? There's new innovative ways of looking at Alzheimer's dementia as brain inflammation, right? But how do we measure that? My patient's not going to say, I have inflammation going in my body unless we actually measure them.
That's right.
So we're actually, as practitioners, just catching up where the field already is. And that's what I'm finding very exciting is that, you actually challenged me. When I was interviewing for Enterhealth, was Dr. Latif, do you know about functional psychiatry? I had peripherally known about it. I didn't have the bandwidth or the time to really pay attention to it. And quite frankly, because it is innovative, not all practitioners out there are really utilizing functional medicine in a comprehensive, patient-centered way. Just testing blindly and getting results without connecting it, integrating it in a patient-centered way doesn't help anyone.
I totally agree with you. Yeah, that was, coming out of really the COVID area, got my mind thinking along these lines because, as you know, in Enterhealth, we have a lot of relationships with various practitioners, ER doctors, internal medicine doctors, a lot of concierge physicians. And one of the things I realized clearly was that during the COVID era, the concierge doctors who had more wherewithal, they weren't connected to big health systems, key point, by the way. They were independent. They were using all of their ingenuity and training and the art, the creativity, critical thinking. They were getting their patients better through COVID without having to send them to the hospitals. As a matter of fact, I went to a dinner one night. It was probably 3 months into COVID, and was sitting there with a group of some of the leading concierge doctors that we know, and they looked me right in the eye and said, the last thing you should do is go to a hospital. This is an outpatient illness. You can treat it as such. And the issue was get the inflammatory effect under control. These inflammatory markers, these cytokine inflammation markers, get them under control early. Let the body rid the virus. You'll be fine. Problem is, so much protocol found its way through the health system. You get it too far downstream, particularly with people that maybe are compromised to an extent, they're done. So that was the impetus for thinking, okay, people that have access to this type of thinking, their health is going to be better because these people are practicing much more objectively. They're running tests that your normal PCP will not run. They actually spend time with you. Not just time with you, they spend time thinking about your labs, thinking about what you told me, putting it together. The time that you spend critically thinking through things is absolutely essential, and I think it's missing in psychiatry today.
It is. I tell people I don't run a Walmart practice, even though Walmart's a 500 Fortune company, right? 15-minute med checks is not what I went to med school for. Interestingly, when I was driving up here today, I was thinking about, how I've arrived to this place. And when I look back, there's so much kind of points that just make sense in a culmination that I wouldn't even have had the thought to approach clinical care in this way 10 years ago. So fascinating thing that came to me was my father, who passed away a couple of years ago, he was a retired psychiatrist, but his original training was in surgery. So marrying that hardcore body science with the art of understanding was something that you really had to be intentional and think about to arrive in that place, right? So the time to actually synthesize and collect all of these data points really requires an intentionality that our current health care system, it's this frenetic pace of I need to get to my next patient.
I know.
I talked to some of my very good friends in corporate medicine who are CEOs and stuff, who are CEOs, and it's one of those things, if you know, you know.
That's right.
Our ethos in medical school is primum non nocere. First, do no harm.
Right.
Why have we forgotten that, right? Bringing that forward to today in functional medicine, functional psychiatry, addiction 3.0, is you have to have that. You cannot ignore the core foundational science to be able to separate what's good versus what's harmful for the patient.
That's right.
You know, one of my professors in med school said, being a nice doctor is optional. Being a competent one is not, right? So you have to balance both things.
That's right.
And I think I keep bringing back to when patients arrive to us with co-occurring diagnoses, we have to look beyond where their life got interrupted in their functional experiences. And currently standard of care is get them a medical detox in 7 days and then 30 meetings in 30 days and an outpatient program.
That's right.
And it's almost like we've lowered our goal for treatment, lowered our standards on, we're doing a pretty good job if we just got them back to the point where their life was interrupted. Well, my challenge is, why can we not get them to a path of recovery where they're thriving?
I agree.
Right? If anything, that incident of their relapse was actually a point of inflection in their life to the better.
That's right.
Right? But we have to then meet the patient and help them see that hope beyond it in a way where they're not only feeling heard, but they're coming to clinical professionals for a competent, authoritative opinion.
That's right.
Right? Our patients are informed. I've had patients who've chat GPT'd me within 2 sessions, and we've had some really good conversations about that. How do you synthesize all the information out there and say, no, for you, with your lived experience, with these biomarkers, with this genetic variation, with these trauma-informed understandings of your life, how do we create a customized treatment plan that is innovative, right? How do we not just use medications, but more precision medicine, right?
That's right.
30% of the general population has genetic variations in their liver that will impact in one way or another how they'll metabolize the medicine pharmacokinetically and how it will get to your brain pharmacodynamically. Why is that not standard of care?
I don't understand that. Yeah. But things like what you just said, most people don't understand. Yeah. But the analysis, the objective testing is not done in order to arrive at those conclusions.
Simple things, right? So things, and what's interesting as I'm learning about this is all of these data points are sitting out on a shelf here and in a book there and in a case study there.
Right.
We really need to kind of bring that together in a comprehensive way. And that's what I'm excited about with my year-long now fellowship with integrative and functional psychiatry with Dr. Greenblatt.
That's right.
Getting that mentorship, because keeping that curious learning growth mindset is helping me first and foremost. And then I'm able to better help my patients.
I completely agree. And I feel like in pretty much any line of work, having that healthy sense of curiosity is really important. But I think in our space, there is so much room to still learn. So I love the fact that we're on this journey together. Let's kind of just dive a little bit into this, because I want to give people a feel for let's give them a little tangible. What are we talking about here? When we say functional psychiatry, what are we doing? Like, what are we looking at? What are the tests that we're running? Yeah. Maybe just give people, I know there's a variety of biomarkers, and this is probably a white paper we should do at some point. Yeah. However, generally speaking, what are we looking at and why? Yeah. Let's give people a feel for that.
So I'm going to take an opportunity to put a plug for my new newsletter called Psychiatry 3.0.
Love it.
That's actually going live next week. I did a year-long post-grad training at Harvard called Effective Writing in Healthcare. And one of the core tenets was that good writing is good thinking. Writing is thinking. Writing is learning. So what I plan to do is all of these things that I'm learning that are evidence-informed, just publish some blog posts about it. Let's talk about lithium orotate. Let's talk about zinc deficiency. Let's talk about gut inflammation. Let's talk about using intrinsic alpha rhythm biomarkers in functional medicine. And so in essence, it's a long conversation that's ongoing. But to give a taste, right? Let's say I have a patient who's coming to me and says, "Look, doc, I've been on 12 different medications. I've even tried traditional TMS." Right?
That's right.
And I'm not seeing optimal results, right? And what can you offer me other than yet one more trial of a medicine for me feeling good until it stops working again?
That's right.
Right? Or a patient who's coming in who's struggling with a consistent sense of just lack of energy, brain fog, lethargy, and no one's really tested their thyroid, no one's really tested their cryptopyruria, some of those things. So for what functional medicine is it's beyond just testing. Functional medicine would be an individualized approach. Functional psychiatry would be an individualized approach where we first do a little bit more detailed, deep dive into their lived experience, their history, but also their generational history, going back a few generations. Does trauma live in this family tree? What are the epigenetics of that? Does addiction live in that? And then that'll inform us, why is someone more prone to addictive behaviors or not? Is there a genetic component to it? So we'll do genetic testing. And what I'm learning is that there's actually evidence-informed genetic testing that goes beyond just the gene testing for medication.
Yep.
Because a lot of the testing that we're doing is in our body fluids. It's the expression of those genes in our blood and our urine. And those aren't sometimes a good reflection of what is in the blood-brain barrier, right? The age-old thing in geriatric psychiatry fellowship training was, well, what's the ultimate diagnosis of Alzheimer's dementia? Is a brain biopsy. Well, that's not going to help my patient.
Right.
Who, I can't do a biopsy on them right now. So the same thing is there's certain things that we need to get beyond the blood-brain barrier. So, for example, there's advanced levels of genetic testing that don't look at RNA genetic expression. They're looking at core intrinsic DNA testing, right? Then simple things, right? In medicine, one of the maxims is when you hear hoofbeats, think horses, not zebras. And sometimes we overcomplicate things, right? Let's measure micronutrients. And why are they important, right? Zinc is an essential power horse for a powerhouse for our brain. Metabolism, energy. Magnesium is a chill pill, right? It's an element that calms our nervous system down. But one of the things, for example, that we've known in addiction medicine, but we've not connected the dots, is when a patient who comes in with a severe chronic bout of drinking consistently, where their gut absorption actually intrinsically gets changed and thiamine and folate absorption gets impacted. We've known for a long time, our medicine colleagues used to give banana bags in the detox, right? They're putting those essential elements missing, because if we don't do that, the lower posterior column in your spinal cord is so impacted that you start seeing the impact of chronic alcoholism in a very neurological way, right? So I could be working upstream in trying to keep giving medicines for a patient that essentially are not adding serotonin or adding norepinephrine. They're just reuptake inhibitors, allowing the synaptic space to stay open and functional longer. But if the building blocks are not there, something as simple as an MTHFR gene, which doesn't convert folic acid into methyl folate, that is an essential nutrient, I could do blood tests peripherally and have folic acid levels perfectly fine, and yet the medicines aren't working, right? So functional psychiatry is this very root cause search into different domains, right? Let's look at your gut health. Let's look at your brain health. Let's look at your genetic individuality. And then we're on a more science-based supplement enhancement that has to be tied with integrative medicine, because that's the key thing that I'm seeing in some practices of functional medicine is it's either just these thousands of dollars of tests,
That's right,
but we're not looking at core lifestyle things, right?
Yep.
So I can't correct that patient's gut inflammation if it's 4 Whataburgers before breakfast.
That's right. They're going to have to change some behavior.
You have to change the behaviors, and you have to bring all of those things into it. There's some fascinating research that now is no longer bench-side, but we can test for our adrenal systems, where patients who are stuck in a chronic level of fight or flight. But again, if we don't test it, how will we know?
That's right.
So once we've done that, we've got the blood test, and you have that discussion with the patient. I think that's a critical thing that we haven't had time in medicine to carve out because it's not billable.
That's right.
Right? Let's sit down and let me help you as a scientist to translate this data to what does that mean for you? So if I'm giving you a certain modification prescriptive, you understand what the why of that is, right? And then that's just the first building block. Mm-hmm. And the issue is that you can measure 200 biomarkers. And again, it prints out a very pretty fancy report, but how do you have the knowledge and the experience to synthesize where do I need to prioritize first?
Right.
Because otherwise, I literally have a patient yesterday who the nurse called me and said, and they were with a different practitioner who they said she's literally feeling like vomiting because the amount of supplements she has in her hand are too much. Mm-hmm. Right. So functional psychiatry is beyond just one element. It's a whole system of care. Now let's go further. Right. So once we've looked at what the core biology is, where do we need to make an impact in chronic inflammation, micronutrients, so on and so forth. Then genetically, with precision medicine, we're targeting a course of medication. How do we introduce that medicine? Do we start it on a much lower dose? Do we not give up on it because they're slow metabolizers, right? That's just the medicine piece. Mm-hmm. But then how do we now bear upon interventional psychiatry into this, right?
Yep.
We just don't look at TMS as one size fits all, right? We individualize biomarkers for that patient using their intrinsic alpha waves. And then we facilitate a better dialed-in treatment. And now imagine what's happening to the patient. The patient's neurochemistry, brain plasticity, gut availability of nutrients, lifestyle modification, trauma-informed, evidence-based treatment is happening, smart recovery, evidence-based recovery tools are happening. And you're surrounding the patient at Enterhealth with all of these. You're bearing upon the patient everything the best of science tells us and even beyond.
I agree. It is, to me, the most individualized form of care that we can deliver today.
Yeah.
And that's the point. Like with this functional medicine, it is you're looking at very unique biomarkers. If you and I went through the blood test, you're going to find very unique things between us both. Yeah. And then you come in, assess, analyze with all the other assessments that you've done, you put a treatment plan together. Yeah. So give me a feel for, since we've been doing this, what are, just generally speaking, are we seeing some interesting things in the testing with our patients? Because our patients have been using, they use substances, they have underlying dual disorder issues that is very common in our space. But what are you seeing? What are there some unique biomarkers, some repetition, some consistency in some areas that you're like, this is pretty interesting?
Yeah. So even just on early testing, so one of the things I'm excited is over the course of this year, we're going to be collecting different data points. And with this framework, looking curiously at patterns. Are we seeing beyond the general population certain labs that are abnormal that might be correlated with an increased risk of propensity towards addiction or an increased risk towards a protracted level of mental health issues, as well as a brittle path in recovery and relapse?
Yep.
So looking at the core essentials, beyond thyroid testing, looking at thyroid antibodies, looking at vitamins, looking at minerals. Yep. There's an interesting test, cryptopyroluria, that was researched many decades ago. And again, there wasn't funding, so it was put to the side. And it's fascinating because some people genetically express this more than others. And what happens is that when cryptopyrrole is excreted in the urine, it is leaching vitamin B6 and zinc with it. So patients are in a deficit state. And the solution is elegantly simple, right? You look at the test, you see that clearly evidence-based objectively, this patient is standards of degree deviated from the normal ranges in the general population. Let's start introducing those things. So what we're seeing early on in treatment is patients' general sense of well-being. I'm sleeping better. My brain fog is better. My post-acute withdrawals are better. I'm quickly able to get engaged in therapy better. Hey, doc, can I get off of the detox unit so I can get back into the therapy place and stuff? So that's just early things we're seeing without even innovating any new treatments. What I'm really excited about is what can we learn from functional medicine, that there is early research, for example, the role of NAC in accelerating post-acute withdrawals or even in cravings. What is the role of GLPs, that we're seeing a lot of good clinical data coming on?
Correct.
And stuff. And we don't want to jump the gun.
Yep.
But one of the things that I keep coming back to the word, the art of medicine, right? FDA allows off-label use because implicitly there's a recognition in healthcare that physicians advance the field of medicine and knowledge by practicing medicine.
Yep.
As long as we first do no harm.
Right.
But I think not introducing some of these science-based things in the deployment of our patient care is a form of doing harm also.
Correct.
Yeah.
That's great. It's a great point. As you had mentioned this just a little bit as you were kind of going through that, and this approach, these supplements, the different types of treatments we'll be deploying, they're not necessarily at the exclusion of using what's already in your traditional repertoire, correct? These interrelate. They go hand in glove, if you will.
Yes. So great point, right? So there's a narrative right now about deprescribing medications, and this isn't a new one. Some of this narrative is actually based on good science. Again, the first true biomarker for our patients is a story they tell us. And patients have been telling us, there's a small set of patients on the outlier of a normative patient database that have told us they've had difficulty coming off of medications, or the burden of psychiatric medications has been more functionally impairing than what they came to see cure. So there's a role for looking intentionally at medication, but there's been also decades old from the traditional 12-step, well-meaning practitioners will say, well, if you're in any psychiatric medicine, you're not in true recovery. So again, putting the medical specialty in the center of this is critical to decide, okay, we need medications. We need medication-assisted treatment. We need Suboxone. Suboxone has a critical role in it. We need in recovery. We need Vivitrol. We need naltrexone. In some patients, we do need antidepressants. But what I'm liking about this approach is that it is reducing polypharmacy, right? And you are really holding yourself to a higher standard as a practitioner before writing that prescription pad and bringing that out as your only tool in the toolbox on. Let me collate all of these other data points. Is this really the optimal way to go? So yes, I think you bring up an important question that bears repeating, that functional medicine and functional psychiatry, integrative psychiatry, is not at the exclusion of evidence-based, evidence-informed science.
Correct.
It does not mean that we're kicking out the bulk of what we know works for our patients. We're just advancing the field.
That's exactly right.
Optimizing results because currently the results are suboptimal, and we owe it to our patients to do better.
I'm 100% aligned with you on that. So let's address what I call it the elephant in the room. We've hit on it a little bit throughout this discussion, but this, when I look at it, not being a medical doctor, but coming at it a little bit objectively in terms of why don't, asking a lot of questions, why don't we do these things? Why isn't medicine practiced this way? Yeah. What are the big obstacles in your mind to this being really the standard of care for people that suffer from addiction and mental health? Why can't people get access to this? What are the obstacles?
So I think let's walk through kind of an evolution. just like in medicine, consider psychiatry 1.0 as the good old Freudian psychiatry, right? Psychoanalytically informed therapy. Historically, it had a really good place, but it has its limitations. Then psychiatry evolved into psychiatry 2.0, which is we started to use biological interventions. We started to look at the neurotransmitter paradigm, which has been failing us, right? Because it's incredibly reductive, right? That this is just a measure of one of my pet peeves is when I hear the word chemical imbalance, right? As if you could reduce a patient's lived experience to just a little bit topping up of serotonin and they're good to go. So psychiatry 2.0 is introducing biological interventions, but even ECT, even TMS. And interestingly, Dr. Nolan, who pioneered the SAINT protocol in TMS, which is more advanced, multiple sessions during the day. I was reading in one of his blogs, or he had shared the verbiage psychiatry 3.0 as advanced TMS. But the way I'm interpreting it, that is still psychiatry 2.5, right? Because we're pushing the envelope necessarily and rightfully so, but it's still a biological intervention.
Yep.
Truly to arrive at, how Dr. Greenblatt describes it, psychiatry redefined, or how you kind of challenge, let's reimagine, rethink the delivery of mental health and addiction care. So I think psychiatry 3.0, I would argue, is when you're truly bringing all of these things together.
I agree.
Right? Now, why and what have been the barriers? That would be a whole other podcast. But some of the things we talked about, right? Our systems of care have guardrails around it for multiple reasons that at times don't put the patient or the outcomes, true outcomes, not performative outcomes, right? Net promoter scores and this and that anyone can gain. But actually, is my patient getting better or not? Right. We're not putting them at the center of it. So our healthcare systems, our education, our training, right? I mean, the amount of core biochemistry, psychology, physiology and pathophysiology. My son in his grad school is learning about, things about intraneuronal processes that I didn't know. So is our curriculum in medical science keeping up with these advances or not? Are we limiting and part of this is actually medical legal too, actually. Interestingly, there are well-intentioned, curious physicians out there who are worried about what is restrictively defined as standard of care, right? So there's multiple domains to it. Healthcare system, what is going to be prior authorized, right? What is considered, the ultimate the ultimate irony is the word medically necessary, where everyone but a medical physician is making a determination on that, right? So I think those are some of the things. But also there's an acceleration in brain science outside of the medical field too. Just imagine, I'm curious to learn, we've now arrived upon, as I mentioned earlier, the dementia and Alzheimer's, there's a correlation with inflammation. That is just a software issue. Yep. What about a hardware issue where now we actually have, both me and you, microplastics in our brain?
That's right.
I mean, do we wait for rigorous double-blind clinical control studies with someone's brain biopsy to tell us what to do? Or do we start looking at root cause analysis?
I think you start looking at root cause analysis and unleash the art of medicine. These folks like yourself, they've gone through a lot of training. They're very smart. Let them practice their craft. Get away from the process and the protocols. Let them practice the art of medicine. Yeah. And I think good outcomes will flow from that.
I truly think our patients are going to be the better for it.
I agree with you. Well, as we kind of wind up here, what do you just in your mind, as you look out here over the next 3, 4, 5 years as we're on this journey together, do you see some particular areas in your mind that you're kind of keeping an eye on that you think might show some promise? You hit a little bit on it with the GLP-1s. Are there other things that you say, look, we're maybe we're not quite there yet, but I want to keep an eye on this because they may be evidence-informed practices we might want to integrate in?
So I think AI in healthcare is really going to be interesting. I was part of a startup venture program in mental health, and there was a colleague in there who had a startup that was looking at vocal biomarkers that are early predictors for depression and suicide. I mean, that's just like science fiction out there, right? But they were able to demonstrate a model where data could analyze that catch in your voice, that change in the inflection, a change in the content of your thought narrative, and pick up that data, that signal from the noise much better.
Yep.
So I think those are the things that we're already seeing AI elegantly help our colleagues in radiology, in pathology, where they can do a much quicker analysis of extracting data. But at the end of the day, you have to keep the human in the center of it.
Yep, that's right.
Right?
That's
so
right.
how do I synthesize this data? So I think there's a lot of innovative things, but what I'm actually excited about is that within a period of the next 1 to 2 years, the way that we understand, diagnose, individualize a treatment plan, and give our patients a true collaborative pathway in their recovery is going to start looking very different very quickly in a manner that we're going to make an impact with better outcomes.
Oh, I think you're right. And then you just hit on the key word, the outcomes, something that we've been discussing since you joined us. And I think some of the relationships that we're starting to form, some of these outcome tests that we're working on together with these partners, my hope is that as we go through this, that we can really showcase the results that we're showing, that we're getting for our patients, and be able to publish it and put it out there so that we raise this as really the standard of care for what patients and families deserve that are going through these issues. Yeah.
And have a conversation. Invite other people, invite subject expert matters, bring them to the table to have a true, as long as everyone on that table is aligned with what we're trying to do, I think that collective is just going to inform the general medical field also. Yep. And I'm a big believer of educating not only the public, but also our colleagues, right? Giving them the tools, anticipating what their concerns are, showing them that there's a way, and our outcomes are going to show that. And I'm not a researcher by background, but one of the things that I've learned is we can't be too precious about our data either.
That's right.
It can't be sitting in an ivory tower, and we've got all this knowledge, and some of that where the risk-benefit ratio is so much in favor of let's help the patient with this.
Absolutely.
While knowing what the guardrails are. I think that's what's exciting about looking at the data, being curious about what are we seeing, collating it with patterns that are known in science, and then informing our treatment paradigms based on that.
Yep. Agreed. Well, this has been a great discussion. I love going through this with you. I feel like every week that we're talking about these things, I'm getting smarter on it. I feel like you are too. So thank you for being on this podcast with me. And, most importantly, just thank you for being on this journey with us. Yeah. And look forward to seeing what the future holds for us.
Absolutely. It's been a joy, and I'm really excited to really what all of this distilled knowledge is going to be in the service of our patients, because one of the things we all have to ask ourselves in healthcare, on whose behalf do you occupy this seat?
That's right.
And the day we forget that, we're not practicing medicine then.
Agreed.
Great.
Thank you.
This was a pleasure.